Over to Jose Luis to be host because I'm presenting next. Is that right, Jose Luis? And
let me introduce this wonderful researcher next, and the best paper of the day.
Right.
So go for it, Jill.
Great. And I'm going to be focusing on implementation, which is quite a sexy subject at the moment, isn't it? And particularly as our focus is on social care, the translation of something called nursing associates into social care. And I've called it a bumpy road for implementation. So I know that everybody probably wants to get off in good time for this afternoon, so I'm going to whiz through here. We've written a lot on nursing associates from the health service perspective. And you can see here that we've got various reports, mostly, strangely enough, in the colour purple. I'm not quite sure why, but we've been writing about the introduction of this post within the NHS for a good 2 years now as part of our policy research unit. And we then have turned now to think about it in relation to social care. So for those of you who aren't obsessed by nursing associates, as our team is, I just thought I'll tell you what they are. It's a new role in nursing. It's designed to bridge the gap between health and care assistants and registered nurses, but it is a registered role. So it's that's what really the difference is between other support workers and so on. Its aim is to free up nurses, registered nurses, to focus more on complex clinical care and to help, obviously, with the workforce recruitment and retention problems in health and social care. And indeed the 50,000 extra nurses that were promised in a manifesto for the NHS. As I say, we've been evaluating the introduction of the nursing associate role for a couple of years to see what extent it's achieved the policy aims of providing this new role into nursing and of reducing the skills gap between health and care assistants and registered nurses. And our PPI group have been doing a lot of work by keeping us to task and also reflecting on things such as, is this not just a reinvention of the state enrolled nurse role? What about the inequalities that brought in relation to Black nurses in particular, and so on and so forth? And they've read every report that we've done, and we're incredibly grateful to them for their insights about what it feels like to be on the receiving end of people in this new role. So I'm going to focus on the context in social care, which, as everybody knows, is rather different than the NHS. Nursing associates have been taken up probably in your hospital, your local hospital, as well as mine, mainly in the acute sector rather than primary care. The reasons for that in social care, I'll go on through and think about the approaches and the context overall, and we'll be touching on these very briefly. So the reasons for doing this: why have a trainee nurse associate in social care, not just in the NHS? First of all, there's this point that goes around in social care that there isn't any career development. You might start as a care assistant, may become a senior care worker, but that, unless you really want to go down the managerial route, is it really. It's a very flat hierarchy. There's also a sense, of course, that people want to keep the people who are working in social care with the right values and experience. So an idea of growing your own staff rather than having to recruit new staff all the time. A problem about nursing capacity, that many people in care homes now have very large numbers of multiple long-term conditions, and having some nursing skills is valuable. Equally, bridging gaps between registered staff and non-registered staff, and then, of course, perhaps freeing up some of the nurses who work in care homes or home care agencies to do perhaps more of the clinical work that they should specialise in. So we've got those reasons, and this is a bit of a logic model here, as you can see, that there's a need to recruit, retain and motivate staff, perhaps to improve care quality, leading to a business case, which is very important in adult social care, and also being able to manage new and increasing care needs. So moving on, what did we do? Recently, we've done 34 interviews with people working in adult social care and asked them about nursing associates and trainee nursing associates. That's that T/NA there. One of the interesting things in this area is that it's largely being steered by Health Education England, for whom this is not always an area where they've had greatest experience or anything, but they're working quite closely with Skills for Care. But it is a Health Education England way of working about how you roll out, how you implement a new role or a new procedure and so on. We've been working then with them, well, we interviewed large numbers of people from all over England because this is a national rollout, although there have been some pilot projects. So I'm just going to comment on numbers and patterns, approaches, the rationale and the challenges. So, of course, everybody's interested in the adult social care workforce, isn't it? You can't move without some parliamentary committee saying workforce is the issue. People say, users and carers say that workforce is the big issue. And so this is one perhaps approach of getting a workforce that is well paid, that will, or better paid, will have a career structure. As we'll see, though, there are a large number of variations when that takes through. And this is where the variations, some of them lie. You can see that Health Education England has ambition of 300 is not entirely met yet. We've probably got about 132, and there's a little bit of geographical variation. And these are the big players. They're pilots for Health Education England. Overall, though, what does that mean? It means that you're probably unlikely to bump into a nursing associate in adult social care on the bus. There are not many of them. For some reason, the North East probably wins the prize, and I don't know what's happening in South Yorkshire, but not very many. The slightly different colours here are rather technical bits about who's been a pilot and who hasn't, but we've not got time for that. Just to focus on Manchester, I know there's some people from Manchester here. What does that mean in reality? It means there are tiny, tiny numbers. If we take Belong Care Villages, which is the old Part 3 provision that is in the area of Staffordshire in particular, they've got one nursing associate. Other places manage to get 2 and maybe even 3, but these are tiny, tiny numbers. So unlike hospitals where you may have several hundred of them working now, this is still a work in progress. What happens then? There are clearly some leaders of the pack. Some social care providers have seen this as really something they want to do. There's Signet around in the North East. There are other examples from a number of providers, but they are so very small. We're doing some work to try and find out what made them suddenly be the very early and very keen adopters. So what we've been looking at, though, overall is more about engaging, developing and embedding this role. And I'll come on to all these things on the side there just a little bit more. The first is just to say, when you're thinking of developing things in adult social care, it's not like the NHS, is it? There are so many people, so many partners, so many people with an interest in it, let alone the 25,000 registered care providers. So developing this requires what we would say a number of actors. Who's driving it? Very much the same question, that any of those actors could take the role in doing that locally. Who's organising it? Again, probably the employers have a role, but perhaps not. Maybe it's more externally focused. Who keeps the show on the road? Generally employers. And who's involved? As you can see, just about everybody. And where does accountability lie? Well, that's still to be decided. So here is just an example of that, about this rather crowded territory, that some people have responsibilities for funding in some areas, but it all depends. And our new friends on the block, the integrated care systems, will probably be doing a lot more in this area as well. So just on the area of funding, it can come from various sources. And in the area of providing placements, which if you work in professional education really dominates your life, again, that can be a number of different people trying to do different things, or perhaps revealing some gaps. So there's both synergies of people working together, but actually there's quite a risk of duplication or functional equivalence. So challenges then, many. First of all, it is complex, isn't it? A simple role like this, nursing associates, not 7 years of medical school. It's a 2-year pre-degree award. It's not that complex, but there are many complexities when you try and move it from the NHS to social care. It doesn't help to do something new during a pandemic in many ways. The sector context was moving and shaping, and as you can see even from our Manchester example, there are some multiple providers doing very different things. And then the infrastructure for the development of a new role adds to the complexity too. So purposes, we've touched on that do you need to have nursing associates? Possibly adult social care was not asked that question very much in the early days. Some people would say that they already have people who can do nursing work. There's something called a care home practitioner. It's a 10-week course, not a 2-year one. So debate then within adult social care about the necessary for it. Where do people get information and advice? They get it mainly from Skills for Care. And Skills for Care, unlike Health Education England, are the place that people in adult social care go for information, advice, if you're an employer. There are massive problems and complexities around funding, who pays for backfill cover when they're doing a day a week at the local HEI, how do you move all that money around, what do you do with the levy because it's apprenticeship money, how do you replace people when they're on placement, etc. You name it, that was a complicated area. And there are champions, people quite like it, even those can manage the corporate complexity. Education providers, the universities that many of us work in, some of them like nursing associate programs and have leapt into this as a new area of work. Some of them are sitting on the sidelines wondering whether or not that will dilute the nursing roles that they already provide. And some sensitivity around the nursing profession as well. And recruiting, is this a career for people already working in social care, or is it a new pool of labour that we want to get in? Still questions under debate. As I've said, in development, placements are difficult. What do you do with somebody who's working in your care home when they have to go to another agency and have a placement? How do you manage all that? Difficult. And where do you find these places too? Who's going to supervise the nursing associate if you haven't got a nurse on post or they're very stretched? What about this idea of a learning culture and opportunities in which mentors and all the things that come with the hospital, big education provision, just isn't there in a very small care home? Where do the academics fit in relation to this? Because they've got a relationship with the NHS providers, but not necessarily with the home care agency and so on. And something like protected learning time might sound grand, but as we know in adult social care, actually protecting any time is rather hard to do. And then lastly, of course, pay, the apprenticeship pay, is that okay for people? And when they qualify, what level will they be paid on? Because in the NHS, much more easy to say, this is agenda for change, band levels 5 and 6 and 4. So embedding them, goodness me, you've only just got to grips with the nursing associates, and then you've got to deal with them as full-time members of staff and work out how their continuing professional development will go, what scope of practice they'll have, what can they do that a registered nurse can do, what's the difference between them and a senior care, what about their governance and what does the CQC think of it all, and how do you argue this throughout all the other places that are interested in skills, such as the clinical commissioning group or now the integrated care system. So some legitimacy questions arise, but in the NHS, those are falling away. There are most places quite like nursing associates in their hospital and indeed in primary care. But of course, the cost issue for social care is really important if you're having to pay upfront to train your staff, some of whom might then, with this qualification, move on elsewhere. So the future of this, we're setting the future in two things, really. What is the role of nurses in social care, in adult social care? We did an evidence review recently and that really helped us think through what actually the nurses are doing. There are a lot of nurses working in adult social care. They are the main professional workforce. but some tensions about what is their role as leaders, clinical experts, what are they supposed to be doing? And then setting this in the context of the implementation literature, how do you draw on this as an example of how things can be implemented well and not so well? So what's our next step as a policy research unit is to look at, again, around whether the purpose is still the same, whether or not we're reaching saturation, even in these small numbers. What do nursing associates do when they've qualified and 2 years, 3 years qualifying, move on? Perhaps have some case studies, which will be a little bit easier to do, hopefully in the near future. Now we can go places following COVID, and then perhaps to do some small survey work with their more employers, and equally with the higher education people involved in this work too, because as I've explained, there are an awful lot of players in this territory. So I've rattled through there. Hopefully people will have questions. If not, I'd like to thank people for this opportunity to talk about workforce during this afternoon, because I think that's a really important work, a piece of a really important area that the PRUs can help with in thinking about adult social care policy. Thank you for listening.
Thank you very much, Jill. There's nothing like having you present to keeping people engaged in the last session of the day. Wonderful stuff. We do have some comments and questions. Gemma, do you want to ask your question?
Yeah, I guess I was just interested in whether you saw any issues around the nurse associate trying to navigate the line between cultures of care, or navigating like the medicalisation of care.
Yeah, I think when we get out to talk to people in the in the agencies, that'll be a really important thing to do. Are they the equivalents of nurses who are in charge of the meds? So they wheel the drug trolley around, which is what many nurses in adult social care have said they don't like doing. They really want to think of new ways of working, which aren't necessarily medical. And how do they manage that? So I think that will be, ideally that would be by observation, wouldn't it? But it may be that we have perhaps some more discursive interviews with individuals, and we see them in the context of where they work, which might be a retirement village, perhaps be quite different in home care and so on. But I think you're right that the colleagues in Scotland have been talking about the danger of social care becoming very medicalised, with all this emphasis on complex and multiple needs and everything, and really important to keep an eye on that.
Be really interesting to see how that works.
Yeah.
So if I may, I'll ask you a question, Jill. You've talked about the business case, the need for a business case as the end of the sort of that load development model. And I was just thinking, well, here you are training people in the social care sector with more health care sector skills, and some of the substitutes, you've mentioned already the risk that as a result then they will go into the NHS. But in addition, I guess some of the substitutions that are happening are with NHS costs. So you're helping reduce the demand for NHS activity. And I was wondering whether that's also something that, I'm not going to see all of the benefits. If as a social care sort of commissioner, I now pay for, more expensive workforce that has got better healthcare sort of skills, I'm actually helping the NHS, not myself, in terms of the business model. You see the business case that you were describing. Is that an issue, or is that just a twisted mind of an economist?
No, I think that is always the case, isn't it? About is the moral purpose of adult social care to save the NHS? It's possibly not the way that many people in social care see it. So it's about, doing the right thing for the right reasons. And it may be that having some people with more clinical skills will mean that people will have better quality of life at home, within the care home, and so on. And other staff will be able to learn from them and have greater confidence. And perhaps they'll be better managers too, because they see that things are, they can see things from multiple perspectives. So I think the business case does have to stack up, really. And perhaps one of the problems of having something in the NHS to start with, rather than create it with the social care in mind from the word go, is that sums get done with NHS pounds and pence, rather than social care pounds and pence, which are a little bit different. I can see, Debbie, did you have your hand up?
It was a sort of related question about medicines management, Jill, which I know is one of the issues that in our British Society of Gerontology Conference Symposium, one of the papers is about the increasing expectation of social work carers to undertake medicines management and the sort of risks associated with that. So I was thinking about these synergies and whether the concept is that those highly medicalized aspects or increasingly medicalized aspects of social care would fall to this new group of workers, or whether the concept is something somewhat different from that. So it's a bit of a muddled question, but I was stimulated by knowing that that's a big issue within the care sector.
Well, it's not only medicines, is it? It's all the gizmos and gadgets that have been cropping up in COVID quite a lot. And one of the key things that has happened in COVID has been a sudden urgency to train care staff into doing quite what would be seen previously as clinical work.
Yeah, exactly. Yeah.
And whether or not that will be rolled back or people will keep that interest in this. There are big issues of insurance, governance, regulation, and so on. But I suppose COVID has made it possible for people to think outside the tent about what can be done. Most medicine management, though, in many care facilities is done by residents themselves, where possible, probably not for people with severe cognitive impairment, but the idea is that you manage your own medicines as far as you can do. Which is good. There's a question from Catherine saying, is it more common in North America? Yes, to have these substrata roles for nurses is what happens both in North America and in Europe, to have people who've done 2-year courses and who staff often long-term care facilities. So it is, you can see some of the arguments of the nurses saying, well, we went to do a degree for 3 years to give us a proper status profession, and now you're reinventing this substrata profession again. And that debate happens quite a lot in nursing.
Martin, yeah, sorry. Martin, I think you wanted to ask a question.
Yeah, it's a comment and a question. The comment, I mean, hosted with you said we were going to have the best presentation now, and I'm going to disagree. I think Jill was only equal best with everybody else. I think they've all been wonderful. So, but it was wonderful, Jill. Thank you. The question is about integrated care systems and whether all of that is going to change things. So, what's going to happen in relation to this group of staff?
Well, I don't suppose they are at the top of their agenda. I think you would have to say that this is not their relationship with HEIs and all those complexities of finance and so on through apprenticeships, levies and things depends very much on whether the integrated care system is inheriting quite a lot of the structure of the CCG or wants to start with a bit of a blank slate around training and development. I think we'll see, probably my prediction will be, we'll see continual variation locally. And that some places will see that this really fits them and so on. Equally, local authorities have been quite keen to see that if they've been in an area where their nursing provision has decreased in adult social care, they see this as perhaps a very helpful way of getting homes to continue to be care homes registered for nursing. As opposed to redropping their registration. So it doesn't make a simple answer, does it? But I think the main thing is watch this space, but I would predict that there will be even greater variation within the 54 ICBs than we have seen previously. But of course, if we work in social care, we know there's 152 local authorities and they are all genetically different. So we perhaps are used to diversity, aren't we?
There is also a question about when, well, I think it looks as if you've got some output already out there or not.
Yes, we've got 7 reports on the NHS ones, and we've got our adult social care report just about to come out. So that will be on our website and tweeted mercilessly in the next few days.
And the link has just been provided.
The link has been put up by my colleague. Thank you, Joe.
So, any other questions or comments? If not, all this left is to thank all the speakers for fantastic presentations. I think it's been a great first day. There will be more. We are recording all the sessions, so we're hoping that in due course they will all be up online so that we can look at them again. And yeah, and hopefully see you tomorrow at 2 p.m., slightly later than today. Thank you very much again to Jill and all the other presenters.
Thanks, everyone. Bye.